So I'm happy to speak on behalf of the Hamdan Medical Journal about the long-term follow-up and late effects in pediatric patients. If we look at pediatric cancer patients today, we know that they achieve more than 70% long-term survival rate nowadays. That means that one patient in 1,000 adolescents and young adults is a survivor of childhood cancer. And that means that there is the need of accurate diagnosis and treatment of late effects with early identification, comprehensive intervention and treatment, and establishment of multidisciplinary preventive health care. There are some specific pediatric issues, which was very nicely shown by Michael Pulsifer and published in BBMT 2012. If you look at these recommendations, they are well risk-based and exposure-related, and some of them are from the Children's Oncology Group or the Joint Transplant Society or from the UK guidelines, and there's a new initiative by the PanCare group. But in pediatric patients, that means that there are very few prospective pediatric studies. So looking at late effects in pediatric patients or in patients with after childhood cancer, those late effects are multifactorial and influenced by genetic disposition, developmental stage and psychosocial background, the kind of malignant disease and the comorbidities, and of course the exposure to chemo and radiotherapy or to stem cell transplantation with different conditioning regimens, IG, total body irradiation. And of course, the course of the follow-up after the chemotherapy or after the transplantation is very important. So we have to look at the early complications and their therapy. And we have to look at the amount of organ toxicity, infections, immune dysregulation and immune deficiency, and at all the complications of stem cell transplantation like graft versus host disease and the immunosuppressive therapy. So there was a very nice study by Oeffinger published in NIME 2006, and they looked at chronic health conditions in survivors of childhood cancer after 5 years. 10,397 survivors were included and compared to more than 3,000 siblings. What they did is they looked or they graded the late effects according to the CTC, and they graded into mild, moderate, severe, life-threatening or disabling late effects, and grade 5 meant death. And if you look at I just want to show you some of the results. If you look at the grade 3 and grade 4 late effects, you can see very easily that the survivors have 20% of the survivors showed grade 3 late effects and chronic health conditions compared to the siblings with only 4.2% of the siblings showed these chronic health conditions. So in pediatric patients, it means that the age at the intensive therapy or the age at the stem cell transplantation is very important. Children are particularly vulnerable to late effects because of the immaturity of their organs and the impairment of the development potential. So we have an extended period to deal with long-term complications. And we have a difficult transition from the pediatric to the adult medicine. So what is the spectrum of the late effects? Late effects comprise endocrinopathies, of course a lot of different organ dysfunctions like pulmonary complications, cardiovascular complications, sequelae regarding the gastrointestinal tract and the liver, renal dysfunctions, vision, hearing, oral and dental problems, and some other developmental disorders like musculoskeletal disorders, neurological and cognitive consequences, and psychosocial sequelae. And of course, last but not least, and very important, especially in the long-term follow-up, secondary neoplasms, which are unfortunately often malignant. So I now want to show you more common or important late effects in the different organ systems. So if we look at the central nervous system, we can find leukoencephalopathy, cerebral atrophy, demineralizing microangiopathy, or peripheral polyneuropathy. The patients can show as clinical symptoms fatigue, headache, epilepsy, or other neurocognitive deficits. And with the limited, and they show that a limited age-appropriate daily activity. So which patients are at risk for that? Patients who are at younger age at the transplantation or the high-dose chemotherapy, patients who got total body irradiation plus or alone cranial irradiation, who got busulfan, thiotepa, melphalan, and MTX. And dealing with patients after stem cell transplantation, those patients who had chronic GVHD are at a special risk, or those patients who needed a long-term steroid therapy. If we look at the psychosocial sequelae, we have to keep in mind that there's a broad overlap and often a very subtle onset. Those patients can show behavioral problems like reduced social skills and social integration, or the interaction may be not age appropriate. Those kids can have educational problems like schooling problems, and later we see a higher unemployment rate. And of course they can have psychological problems with depression or excessive mood swings. If we look at the hearing problems, the risk factors are if they had cyclophosphamide, thiotepa, cis and carboplatin, again, total body irradiation and cranial irradiation. As a take-home message, please be aware that school problems and cognitive deficits may be due to a coexisting hearing loss. Dealing with vision problems, the mostly clinical manifestations are cataract, which can be quite often with a late onset, Sika syndrome, or macrovascular retinopathy, especially in those patients who have been on a long-term cyclosporin A therapy. The risk factors for this patient group is again total body irradiation and cranial irradiation, and again a long-term steroid therapy. In our pediatric patient group, we have to be aware that children often don't communicate dry eye systems. So in this cohort, photophobia may be the first or only symptom of Sika syndrome. And looking at the diagnostic possibilities, Schirmer test is often not applicable in pediatric patients. Looking at the oral and dental sequelae, we find in our pediatric patients dental caries, enamel hypoplasia, microdontia, and arrested root development, malocclusions, and salivary dysfunction and chronic mucositis. Patients who had a younger age at high-dose chemotherapy and stem cell transplantation are at higher risk. Patients who had TBI and cranial irradiation and chronic GVHD again are at a higher risk too. In this, we are dealing with these problems. Children rarely communicate dry mouth symptoms, and one of the symptoms could be excessive drinking during eating and malnutrition. Looking at the pulmonary complications, the risk factors are again the irradiation, total body irradiation and chest irradiation, the use of busulfan, MTX, again those patients with chronic GVHD, plus minus IgG or IgA deficiencies and chronic infections are at special risk. The clinical manifestations of pulmonary late effects are obstructive and restrictive respiratory dysfunctions and bronchiolitis obliterans. The problem, especially in young children, is that the lung function test needs a pediatric experienced pulmonologist, and it needs serial testing for good results. Looking at the cardiovascular late effects, the risk factors are anthracycline treatment over 250 milligram per square meter, the use of cyclophosphamide above 150 milligram per kg, and again, as mostly always, the use of total body irradiation and chest irradiation, and in patients with iron overload, there is a higher risk for cardiovascular late effects too. The clinical manifestations are well known, but please keep in mind that often again there is a very subtle onset in pediatric patients, and this may increase over the time, which means for the long-term follow-up this has to be considered. Estrogen deficiency and metabolic syndrome may predispose to increasing cardiac late effects. Looking at the renal complications in the long-term follow-up, the risk factors are always TBI and local irradiation, the use of cisplatin and carboplatin, the use of calcineurin inhibitors, and long-term virostatic therapy. And clinical manifestations can be either tubular or glomerular toxicity and thrombotic microangiopathy and nephrotic syndrome. Looking at the gastrointestinal tract and the liver, the risk factors are quite similar. The clinical manifestations are often dysphagia, pain, irritable bowel syndrome, malnutrition, and hyperbilirubinemia. Regarding the skeletal disorders, the risk factors are a little bit different. So if the patients are at older age, at stem cell transplantation or high-dose chemotherapy, they are at higher risk. Of course, irradiation again is a risk factor, and GVHD. Again, the long-term steroid therapy does harm these patients, and additionally, malnutrition, catabolism, physical inactivity, and hypogonadism puts this patient at risk for this sequelae. The clinical manifestations are osteopenia, osteoporosis, and avascular necrosis. Please keep in mind that there are no pediatric data about the relationship between the bone mineral density changes and the fracture risk. Looking at the endocrine late effects, we have to talk about the thyroid, the gonadal, and the adrenal dysfunction, which together are one of the most common late effects. And they show an incidence between 20 to 50% of the adult survivors. Looking at the younger patients, we find growth retardation quite often. Those endocrine late effects are found in the group of patients who got radiation of their hormone-producing glands, like the pituitary gland if they had brain irradiation, or the thyroid if they had neck radiation, the ovaries and the testes. And again, after stem cell transplantation, but in contrast to other late effects, especially if they had busulfan conditioning. There's a very nice sentence by Jean Sanders. She always called busulfan the liquid TBI because the amount of late effects was the same, nearly the same. If we look at the growth, the risk factors are irradiation and high-dose chemotherapy before transplantation and the long-term steroid therapy. And we have to keep in mind that growth is a very multifactorial